Good morning, everybody. Welcome to our Major Unusual Incident Rule Exploring Key Changes training this morning. We are very thankful that you're here. I think we're going to give just a minute to make sure that everybody who's arriving is getting in, and then we will get started. All right, Hannah, how we doing? Are folks getting able to arrive in okay?
Yep, it's starting to slow down a little bit. I think we're good to go.
Okay. All right. Well, good morning, everybody. My name is Scott Phillips, and I manage the MUI unit here for the Ohio Department of Developmental Disabilities. We want to thank you so much for being here today for our MUI rule change update training. We're very excited about the work that's been done, and just wanted to make sure that we got some information out to you as soon as we can. So I'll start with introductions of my crew here. So start, Connie. Do you want to go ahead and introduce yourself?
Absolutely. Thanks, Scott. Good morning. My name is Connie McLaughlin, and I'm one of the managers in the MUI unit, and I'll turn it over to Chris.
Thanks, Connie. I am Chris Young, MUI Regional Manager with the department, and we'll finish off with Dustin.
Hi, everybody. Good morning. I'm Dustin Poor, Regional Manager with MUI. I'm glad you're here.
And of course, we have Hannah Howard, who does such a nice job of managing this provider training series, and she's behind the scenes taking care of all the good stuff. So thank you, Hannah. And Connie, I think you wanted to start with maybe some housekeeping.
Yes, thank you. So first of all, like Dustin said, we're really glad you're here today. We were actually blown away by the interest in this webinar. We have 1,000 of our closest friends and colleagues joining us this morning, and we couldn't be happier about that. We all wish we were just this popular in high school, but you can't have everything. So before we get started, we wanted to go over some housekeeping items. First of all, we hope that you received a copy of today's PowerPoint presentation, the group attendance sheet, and the handouts, which included the rule and the appendices that were emailed last night to those people that registered. We wanted you to know that today's presentation is really going to be a quick overview of the rule changes. And this is just the first of many trainings. In the next 3 months, we will have 10 in-person trainings across the state. We'll also have more webinars. We'll have some short videos. We'll be offering lots of training and technical assistance. We'll be updating our guidance documents that include our frequently asked question and interpretive guidelines. We're going to be making changes to our website, the review tools, the Ohio ITMS application. So we have a lot of work ahead of us, but in the next 3 months, we will be working together with all of you to prepare for that July 1st rule effective date. As far as today, we know there's going to be a lot of questions. There's a lot of material, so we're going to be moving through it rather quickly. We do encourage you to put your questions in the questions section of the Zoom. We're going to leave a few minutes at the end of today's presentation, and we will go over as many questions as we can, but we know we'll have more that we need to address. So our commitment to you is that we are going to have a Q&A document every time we do a training, and we will address your questions in writing. And so those Q&A documents will be posted with this taped webinar probably early next week on our website on the provider training series page. So you will have that in addition to all the handouts that you received. If you are watching this group as a group, we've also included the group attendance sheet. Please type in that Excel spreadsheet. You can email it to myself or Kelly right in our office, and we will make sure that you get a certificate emailed to you within 30 days. We are offering 1 hour of continuing professional development hours for IAs, SSAs, superintendents, business managers. So we want to make sure that that information gets to you. So if you haven't received that email notification of your attendance within 30 days, please email our office and we will make sure to get it to you. And we just appreciate your time today. And I think it speaks volumes to the commitment to Ohio's health and welfare system. So with that, I'm going to turn it over to Scott Phillips.
Thanks, Connie. Yeah, I echo what Connie said. Just appreciate all the excitement and all the interest, and the response was beyond what we expected, and we really appreciate you guys. And I think it says a lot about the health and welfare system in Ohio and the people that are responsible for it. And we appreciate all the effort that you guys have made. Here's the purpose of our today's webinar. We're going to kind of walk through these items. We're going to share a vision of the revised rule, and we're going to talk about that, kind of how we landed with the review rule process, just a little bit of background on that. We're going to touch base on the rule changes, and like Connie said, this is our first training and we only have an hour, and so it's going to be high level. We're going to cover the issues and we're going to try to get to as much as we can, but it's going to be high level. But we got a lot of training happening over the next 3 months where we'll drill down, dig down, answer questions, and be able to address any questions that anybody might have. We are going to discuss the timelines, and I'll just go ahead and make sure that people know July 1st is going to be when this rule is going to be effective. So you hear us talking about 3 months. We've got about 3 months until this is effective. So there's going to be a lot of work that's going on between now and then to make sure that we're training well, we're sharing information well, we're all on the same page, and we're working together well to get that done. And then at the end, we're going to close out by talking about some resources and some future trainings that we have available coming down the road. Next slide there, Connie. So this is just when we think about the rule considerations, and you guys, a lot of you guys know me. I've seen some familiar names on folks that are attending, and I appreciate you so much. You know that I've been around a long time. Multiple 5-year reviews. You guys know that every 5 years we go through an MUI rule review, and I'm proud to say that I think I've been a part of each. And I'm also proud to say that I think we've improved and tried to become better each and every time. And the reason we've been able to do that is because we've had a stakeholder group that's been incredible. And this time was no exception. We had representatives from all areas of our business, all areas of our culture, and we got some really good feedback. The goals we had, and the first goal is this: we want to improve our health and welfare. The system that we got, you guys know this, is one of the best in the nation. I know this because I see a lot of other states, and I get called about Ohio's system all the time. And we are in a really, really good space right now. And it's because of the good work that you do every day, the good work that the county boards do, the good work that we're able to do as a department to try to make sure we're protecting people. And so the goal every time we do a 5-year review is to continue to improve our system. And a lot of conversation this time focused on our quality health and welfare improvement process. You guys know, and you've heard me say it a million times, the MUI system in Ohio is a quality health and welfare improvement process where we want to protect individuals. We want to make sure we look into each incident that happens. We want to make sure that we think about how we can prevent those from happening in the future. And that's what our system's all about. But inevitably, that conversation about, trying to be a system where people feel like it's a gotcha system, or we're looking to blame people, and we've got to do better. We've got to do better from the start to the finish in our system, because that's not what this is about. And you're going to hear from me and other folks about how we're talking about, kind of changing that culture a little bit based on some of the conversations that we had. Another thing we hear from our folks is that, sometimes that the consistency of the implementation of the rule, people had concerns about when we pulled our stakeholder group together. And we want to do everything we can to try to be as consistent as we can be, understanding that, health and welfare and risks and protecting people is not an exact science, right? We all know that, and you know that. But we want to try to be as consistent as we can in the process and the practice. And so there was a lot of conversation at this rule committee about how can we try to do that. And you're going to hear from, I think, Chris Young and some other folks about some ways that we're going to identify maybe some administrative review processes that are going to be different than they have in the past to try to be consistent in how we capture information. The other thing we talked about is reducing administrative burden and trying to do that for everybody. The one thing we heard at the table clearly was there's not enough time in the day to get everything done. So let's prioritize. Let's try to reduce administrative burden where we can and how we can. And I think, again, you're going to see some of the changes that we talk about today is efforts that this committee and we through the department are trying to take a look at to try to reduce some of that and to try to still give us the ability to protect the health and welfare of folks, but do it in a way that kind of coordinates efforts, prioritizes stuff a little differently. And then the last couple things here, I think, if we do that well in reducing our administrative burden, it's going to cause us to have closer communication. And I'm talking about between county boards and providers now. We're going to need to do a lot of collaboration, and also the department. We're going to all have to be on the same page, and we're all going to have to make sure that we're moving through the system in a way that allows us to communicate well, work together well, know what our outline goal is. And nobody on this call disagrees with protecting the health and welfare of people. Everybody believes that, and everybody at the stakeholder group believe that. Where the devil gets in the detail is where we have our differences sometimes, and good communication and collaboration is going to allow us to do better there. And then the last thing, and you've heard this, I'm sure, because I know we shared a lot of information already about the changes. CMS has distributed their access rule. And for those of you that don't know what that is, it's for our piece, it's identifying what critical incident reporting systems have to have in every state in the nation. I will tell you, Ohio is in a great spot right now because we have already about 90% of what the access rule is asking us to have. Some of the changes that we've put into the rule are going to help us get even closer. But I'll tell you, some states are really struggling and may only have 50% of what the access rules require. And so, again, we're in a good spot. We're going to continue to roll forward with this, but some of the changes we made had to do with some of the access rule requirements, and we're trying to get out in front of those because those are going to be expectations within 2 to 3 years for all states. All right, next slide, Connie. So let's talk about the rule process a little bit. I mentioned the incredible group we had. Here's the folks that were represented. I couldn't have asked for a better group. We couldn't have asked for a better group to talk about the rule. We opened the first day and we said, listen, let's talk about what's working well, and let's talk about what we can take a look at and concerns that people have and questions people have and how we can change. And we spent a lot of time going through what's working well and aren't changing any of that. And you're going to see a lot of this rule isn't changed at all because it's working well and things are going right. But the areas you're going to see some of the changes, and we're going to talk about today, were concerns that were brought up by group folks represented on the committee. And part of those folks, you can even see in our first bullet, when we talked about our unanticipated hospitalization definition, that's changed significantly from the last rule. And we're going to share that with you today in some detail. But we also involved some data to get there. We involved our physicians to get there. We involved feedback from providers and boards to get there. And definitely individuals and families to try to make sure that we land in a good spot, particularly with that definition, but actually in every change or everything that we talked about and did differently within this rule. We've asked for information from other states. There's some other states that are doing a really nice job. California, New York are doing a really nice job. And rather than recreate the wheel, we talked to other states and had some feedback and made sure that information is included in our rule that's allowing us to be as efficient and effective as we can be. We engaged a lot of different stakeholders groups, even outside our representatives, to talk about, what's working, what's not working. And that's what we need to do when we do this review every 5 years. And we landed in a place that we feel good about based on those conversations. And we continue to respond to ongoing feedback from our business partners. One thing I can tell you about our group here, and I think you all know this, is that we are really working hard to hear what you have to say and try to think about how we can put things into practice. The only way we get better as a state and in protecting people is to try to work together and collaborate. And that's what I think was a big part of this process and the outcomes that we have here. All right, next slide there, Con. Want to talk about the specific rule changes, and I'm going to kick it off and get us started, and then I want to send it over to some other folks to talk about some other stuff. But the first thing I want to talk about is that situation of kind of the gotcha system, and I wanted to talk about the conversation we had within the group, because we believe strongly that the MUI process is a quality health and welfare improvement process. Do sometimes bad things happen based on mistakes? Absolutely, they do. Do those things have to get reviewed and get improved and get prevented? Absolutely, they do. But what I'm here to tell you is that we also know that sometimes mistakes happen. Sometimes issues occur that couldn't have been prevented. And what we want to do is, through our process, through our practice, is do exactly what we've said here. We want to make sure we create a culture that fosters open communication, universal accountability, learning, and fair treatment of all persons involved. During our conversation here, we talked about something called just culture. And I don't know Probably not everybody on here has an understanding of that, but just culture is basically an outline that says, you know, things do happen. Issues are going to arise. People's health and welfare is going to be impacted. And really, when that happens, sometimes there's three issues that occur. The first is it's a human error. It's a mistake. We're all human. We make mistakes. The second one is somebody kind of knew about a risk and maybe didn't take heed to it or didn't pay enough attention to it. And that's another issue where we find things. And then kind of the final one is somebody's reckless. And when people are reckless and they just don't care and they don't try to protect people, that I think we all agree on how we should handle that. And probably all of us agree on the second one too. If somebody's at risk and shouldn't have been. But the one that we have a lot of conversation about, it seems like, is where there's mistakes. And we want to try to do the best we can to identify what truly happened, think about the action that we take based on the outcome of the investigation or the review, and try to make sure that we think about the whole culture of the work that we do, the service delivery work that we do in the system. So you're going to see, we're going to talk a lot more about this, but you're going to see some language changes within the rule, as mentioned right there. All right, I think I'm getting ready to transition to Chris to talk a little bit about administrative investigations and administrative reviews. You want to take it away, Chris?
Will do. Thanks, Scott. Good morning, everyone. So as Scott mentioned, we had a lot of good discussions in regards to how we could streamline the MUI process. And starting right out the top of the beginning of the rule, you'll see administrative investigations definition, and you'll also see administrative review definition. So instead of all the ABC type categories being under the umbrella of administrative investigations as it currently is, categories are now split between what we call administrative investigations and administrative reviews. For administrative investigations, the IA will continue to complete the investigation so that the cause-determining factors and prevention plans can be developed for those A and B categories, such as those abuse, neglect, misappropriation type cases. So that's the same type process overall. All right. So where we get into a little bit of change relates to what we call administrative reviews. Okay. So again, we're trying to get away from that investigations for all categories. So the administrative review process will consist of those same C type categories, such as the law enforcement, the hospitalizations, and the unapproved behavior supports. So with this process, we feel there will be more of a collaboration between the individual's provider, the IA, the county board, and the individual's team as a whole to develop cause-determining factors and prevention plans for, again, these three types of categories. All right, next slide. All right, so again, for A and B MUIs, the investigator will conduct the investigation via the same type process. All right. For Category C cases, there will now be a mandatory review form with specific questions used for each review type case. So with that being said, there will be three mandatory forms, one for law enforcement, which is now called Appendix C in the rule. We have one for hospitalizations, which will be considered Appendix D of the rule, and unapproved behavior support, which will be considered Appendix E in the rule. So this form will be used as a basis for your report in the ITMS. So as you guys know, we're still doing a lot of work in the ITMS, but the plan moving forward is once those review forms are completed, that is basically going to be your report. Okay, so we also hope that the ITMS is able to mimic those forms. That's the plan moving forward. The provider will submit the administrative review form in Appendix C, D, and E, and the provider will submit the incident report and the administrative review form at the same time. So let's talk a little bit about that piece. So the person who witnessed the incident, again, as in all cases, should be the one writing the incident report and sending to the appropriate person at the provider setting, just as the same process you guys have been doing for years. The provider may then have their director, home manager, or whomever they want to assign to then complete the review form. Again, that's C, D, or E form. And the provider can decide this process and who completes the form and sends to the county board. And we know that the providers will continue to do such good work as they've done for years with that follow-up. Keep in mind, again, we're only filing hospitalizations and unapproved behavior supports when the individual is being provided services at the time of the incident. For law enforcement cases, those are ones we still file regardless where the incident occurred. So if the individual is being served by the provider at the time, the provider would be responsible to complete that review form. If they're not receiving services at the time or with the provider at the time of the incident, the rule indicates that the county board will then be responsible to complete that review form. Okay. So with the review process, the group felt with the provider knowing the person probably better than anyone, right? You guys with individuals every day, transporting all that good important work. They will be able to answer the questions on the form more promptly and more easily, knowing the individual, again, more so than anyone. It was also felt by the committee with the provider assisting in answering many of the form questions, it will allow the eye to focus more on those Appendix A and B type cases. And as we know, investigators, just like providers, have a ton of work on their plate. And again, I think if we're able to streamline this approach as we plan moving forward, the review process will allow providers to become even more so involved and allow the investigative agents to focus more so on those A and B cases. And, for those where maybe staff are put on leave due to the investigations, hopefully, those staff, depending upon the type of case, will be able to get back to work more promptly. Again, freeing up a little bit more of the time for IAs getting away from those Category C cases. And we also looked at consistency across the state. So, right now as regional managers, we see a lot of reports and, we have the current Appendix C that talks about all the questions that should be answered. In some cases, we look at those questions are all answered in a template type format, and others are doing it into a report format. So again, when you look at the form here, we'll talk about here shortly, you'll see questions posed, and that's what we're wanting, again, as the template report to put into the ITMS. When an individual is hospitalized, the provider is responsible for following up with the hospital so that a diagnosis is determined as soon as possible after 48 hours. An incident report is made to the county board and the review form in Appendix D, which is hospitalizations, to this rule submitted when the situation meets the definition of an unanticipated hospitalization. So we know providers are the main point of contact when a person's hospitalized, and we want that to continue. Whether it is a UI hospital stay or meets that MUI criteria, which again, this is going to be another change, and kind of is going to talk a lot about this here shortly, but the hospitalization for the MUI purposes is now indicating, based upon the diagnosis, admission lasting 48 hours or longer. So once that diagnosis is determined and after the 48 hours admissions, the incident report and the form will then be shared with the county board. Right. So this screen has a quick caption of the 3 types of forms. Scott indicated we're not going to be able to go over all these forms, but when you start looking at them, you'll see a lot of similar questions to the current rule, Appendix C. The top portion of each of these forms is what the provider will fill out and then share with the county board. The IA then reviews the form to ensure they are properly coded, finish out any remaining questions, and work with the team on the cause-triggering factors and prevention. So again, 3 types of forms. The provider will be responsible for all 3 of them. Again, unless for law enforcement, they're not a provider at the time of the incident, and the county board would then be responsible to complete that form. So the incident report and these forms would be then sent to the county board for the IA to review and finish out the review process. All right, Dustin, I'll pass it on to you to talk about some more category changes.
Thanks, Chris, and happy Thursday, everyone. Again, glad you're here. There's a big turnout, and I know there's lots of questions. So upon conclusion, just FYI, we'll make sure we address all those questions. I know there's way too many that we could get to in this presentation and a lot of good information here. So I'm going to start with the changes to emotional abuse, and this is a big one, right? So we're replacing verbal abuse, and this update is in alignment with the access rule changes and reads as follows. So emotional abuse means the use of actions, words, gestures, or other communicative means to purposely threaten, coerce, intimidate, harass, or humiliate an individual, or a pattern of behavior that creates a hostile environment. And understanding that there is some language here that has brought about and will continue to bring about a lot of discussion, and will continue to do a lot of guidance and updating of resources, sharing examples, mostly surrounding obviously the change here with pattern of behavior that creates a hostile environment. And like all MUIs, we're going to address those case by case and ensure the consistency with implementation. Additionally, we recognize that prolonged emotional mistreatment has a cumulative effect that can cause psychological harm, even if those actions towards folks seem minor. And again, as we expand further as we get into this interpretation, this definition, some examples that do come to mind though, think of bullying, or say a person is afraid of the dark and staff keep turning off the lights, or a staff is ignoring an individual all the time, which then presents an undesirable behavior response. And we're going to look at those and see if those patterns are forming. So again, key changes here is we have a new category name, expanded definition to include those patterns of behavior that create a hostile environment rather than isolated incidents. As we move into failure to report, the category was updated with some additional clarification points. And you can see the red highlighted text there, the changes, but also what was changed was the removal of reason to believe that an individual has suffered or faced substantial risk, and it's now linked to more defined criteria as spelled out with the category list in red here. And like mentioned before, we're going to continue to assess risk on an individual case-by-case basis, but we also want to keep in mind the difference between failure to report and late reporting, and that difference is based upon the actions taken to mitigate risk at the time of the incident or knowledge of that incident. And so it's important for us to understand, again, actions taken, but how failure to report led to harm or risk of harm. And then, with every investigation into failure to report, we're going to get statements from folks explaining why the failure report happened. And those reports, are going to specify how failure created a substantial risk of harm. And so again, with all of our MUIs, regardless of if MUI, UI, whatever we're capturing as, we're always going to think about those actions, and those are really going to depict if we have a failure to report versus late reporting. When we get into the changes with the death categories, what hasn't changed here is the investigation protocols and the mortality review processes. Those are still intact. Those are exactly the same as they were and will continue to be as such. The big changes here is really, how we're labeling these. So unexplained or unanticipated death means the death of an individual resulting from an accident or that was otherwise unexpected. And then the other change here is death other than unexplained or unanticipated death, and this means the death of an individual by natural causes. Medical emergencies. So the key changes here was clarification that medical emergencies are filed only when completed by a DoD employee or DD employee. Removal of the EpiPen from the definition. So EpiPen situations will no longer be considered medical emergencies. And the expanded definition to include Narcan administration. And there's a lot that goes into this definition. Obviously, we're trying to specify specific examples here, but also clarify who is that person implementing that medical emergency item or procedure. And we also know that obviously there's been an uptick in drug overdoses and issues involving the Narcan administration, all in which we wanted to capture in this definition and clarify a little bit more so than the previous or current standing information in rule. So we're going to keep moving along to missing individual. For this, the category changes is really about differentiating between more serious cases when law enforcement are notified and a person is at immediate risk. And that definition here means law enforcement has been contacted because an individual's whereabouts are unknown and the individual is believed to be at or pose an immediate risk of harm to self or others. And so this aims to reduce over-reporting of low-risk situations while emphasizing the serious cases. Please note that if an individual is missing longer than their service plan allows, but not at immediate risk, it will be a UI or an unusual incident rather than an MUI. And regardless of, if a person is left or not, if law enforcement's involved or not, in these cases, we always want to make sure we're assessing risk. We always want to remember that, if a police report is warranted and needed, that we always do that as applicable. Reporting an MUI should not deter us from calling the police in situations. And so just keep that in mind as we're navigating this category and other MUI related situations and crisis situations that occur. Changes to peer-to-peer. So verbal acts were removed from the peer-to-peer definition. And the rationale there is, really the ability to address that in a manner that is more timely at the provider level. We found that a lot of the peer-to-peer verbal acts were quickly de-escalated and handled at that level. So it made good sense to remove those. And those will now be looked at as unusual incidents or UIs. One thing to consider, though we're removing the verbal act from the peer-to-peer definition, is in cases where verbal acts might rise to the level of, say, menacing. So if there are concerns that we think are escalating, or there's a concern for an individual involved or individuals affected, we would encourage notifying, the proper folks, including law enforcement or children's service, of who may need to be involved there. And depending on the outcome of that, it could be looked at as a law enforcement filing, depending kind of on the outcome there. And the new definition here includes the 4 types as spelled out here: exploitation, theft, physical act, which means physical altercation. It's cut off, but I can tell you it's spelled out as examination of treatment by physician assistant, nurse practitioner. It also involves strangulation, a bloody nose, a bloody lip, black eye, concussion, or biting, which causes breaking of the skin or results in the individual being arrested, incarcerated, or the subject to criminal charges. And last on this list, but not least, is sexual acts involving peer-to-peers. All right, significant injury category changes. So the part of the definition that said is not considered abuse or neglect was removed, and we added verbiage pertaining to dental injuries requiring treatment by a dentist, and that's boldly highlighted there in red. Previous that was guidance. Now it's in rule, and it captures all the other areas here: concussions, broken bones, dislocations, 2nd or 3rd degree burns, or items that require immobilization, casting, or 5 or more sutures. And those distinctions of significant injuries in the system, OITMS, or Ohio Incident Tracking and Monitoring System, are going to be captured as known causes or unknown causes. And I think I'm passing it over to Connie.
Thanks, Dustin. So deep breaths, everyone. We're going to take a pause. No need to put your email in the chat box. We have posted all the handouts in there. You could go to the top of the chat, or we just reposted them. They were emailed out last night to everyone that had registered. It is quite possible that they went to some junk email box, or that maybe it got bounced back because there were so many attachments. So we apologize for that. No need to put your email in the chat. We will email everyone afterwards, but you should be able to find the handouts in the chat right now. Also, if you have any questions, we'd like to request that you put them in the question section of the Zoom. There's a report that we pull to pull all the questions in so we can respond in writing to those. And we want to make sure we do that just because there are so many really good questions in the chat and in the questions section right now that will help us prepare for the rule implementation, but also make sure that we address the questions that you have. So please keep those questions coming. If you have any comments about the training or about how we might improve this for upcoming sessions, please let us know that too. You can put those in the comments. So again, you should be able to find everything in the chat. If not, don't worry about it. We will email you all the information again following this webinar. So I just want to make sure that people are aware of that. So my part of the presentation, I'm going to be talking about unanticipated hospitalizations. And for me, I felt like this was some of the hardest part of the work that we did in the rule committee and also working with other people to get feedback. And I think the reason why there was so much discussion about this is people just care so deeply about people's health and want to make sure that people are living their healthiest, best lives. And so that was a really good starting place for all of us. You know that more than 1 in every 3 MUIs that is filed currently are due to hospitalizations. And so while we're talking about how to make sure everyone's healthy and safe, we also need to look at what kind of resources we have available to us, what we want to focus on, and also what makes the most sense for the people that we support and their teams and their families. So I feel like landed in a really good spot where we are focusing our efforts on the most significant hospitalizations, the ones that are known to be the most prevalent for any person with an intellectual and developmental disability, and ones that are over 48 hours, getting the most serious ones, not the ones that are due to observations or different things like that. And we are focusing in on 6 different kind of diagnoses or conditions. This is not to say that hospitalizations that will not be reviewed under that MUI C and Appendix D of the form are not important. They're all important. Anytime any of us are in the hospital for any amount of time, that's significant, right? And we want to do everything we can to prevent that. But there are going to be some that are going to be reviewed through the administrative review process, and others that will be done through the UI investigation process with the provider. All are important. It's just we want to focus our efforts on some of these different types of hospitalizations that are the most prevalent and also the most filed and also the most preventable. So as part of doing this work, we talked with a lot of experts. We met with our medical director, Dr. Sorg. She came and spoke with the committee. We got feedback from nurses, doctors, from other states, like Scott said, and other state agencies to see how they manage this work. We also reviewed federal requirements and looked at CMS regulations, and we did all of this and had so many good, really good discussions about what makes the most sense. And again, I think we landed in a good place, and there's going to be stuff that we're still going to be working out over the next probably 3 months, and then maybe probably the next year, just as we figure it out all together. But we will figure it out, and we should all be assured that we have good supports in place to make sure whether a person is hospitalized for one of these 6 conditions, or it's a readmission, or it's another type of hospitalization, that all hospitalizations are going to be taken seriously that we're going to try our best to prevent those things from happening. So we want to take a minute to go over what the definition is. And again, it took us a long time to craft this language, and we got feedback from all types of our business partners and families and people getting services. And this is where we landed. So unanticipated hospitalization that's going to require administrative review is any hospitalization that's over 48 hours or more. So again, cutting out those hospitalizations that maybe people go in for observation, and it's not considered a planned procedure or a test or anything like that. And it includes one of the 6 diagnoses listed here. So it's a person that is diagnosed with aspiration pneumonia, bowel obstruction, dehydration, a medication error, and that was a specific call out from the access rule. If the 48-hour hospitalization was due to seizures and it wasn't part of a planned procedure, if it was due to sepsis, those all are going to require administrative reviews. And you might recognize these diagnoses again because they're the ones where we have the highest rate of hospitalizations for Ohioans with developmental disabilities. They're also the categories where we see the most frequent causes of death. So infection, and aspiration pneumonia. I also might recognize these because they're often referred to in our systems as the fatal 5. So all of these, with the exception of medication errors, are ones that are really prevalent and preventable among the people that we support. And so that is how we came up with those types of hospitalizations that would require a MUI and an administrative review. And again, that's not to say that the others are not important. They are very important. The other part to the unanticipated hospitalization definition is Part B. And that talks about any hospital readmission lasting more than 48 hours. And again, it's not a planned evaluation. It's not a planned test or a procedure, and that's for any diagnosis. So we have on Part A talks about, hospitalization over 48 hours, not planned for those 6 different diagnoses. And then we have Part B, which is any hospital readmission. So 2 hospitalizations within a 30 calendar days and the same diagnosis. So that could be I go to the hospital, I stay in the hospital over 48 hours for the flu. I'm diagnosed with the flu, as many people have been this year. Then I'm discharged home, and within a week, I go back to the hospital and I'm readmitted and diagnosed with the flu again, and I stay over 48 hours. Those 2 readmissions are going to be reported as a unanticipated hospitalization. So for this part of the rule, it's any readmission over 48 hours within the same 30 calendar days and for the same diagnosis. And I think to illustrate this, it's probably easiest to go over some examples. So take, for example, Janet. She's hospitalized for over 48 hours due to seizures. Now for Janet, she has a known condition of epilepsy. She's regularly seen by her neurologist. Her Ohio ISP talks about the supports that her team surrounds her with to make sure that her seizures are monitored, that her medication is well controlled. But if Janet goes to the hospital for a seizure and it lasts more than 48 hours, that is going to be reported as an unanticipated hospitalization because A, it meets that 48-hour requirement, and B, it's for one of the 6 listed diagnoses, which is seizures. The next example is an example of a readmission. And this talks about Jim, who has some mental health diagnoses. And Jim is first hospitalized for 3 days for having hallucinations and threatening self-harm. He goes home, he's discharged, and then he's readmitted 2 weeks later, so still in that 30 calendar days, and for the same diagnosis, and he stays more than 48 hours. We know that this is going to take a lot of coordination on the provider's part. We also know that sometimes diagnoses are difficult to ascertain from the hospital. So what our feedback to providers will be, do not report an MUI, whether it's the 6 conditions that we talked about in part A of this definition, or B, until you know for a fact that criteria has been met. So if I'm taking Johnny to the hospital for a seizure, don't call and report that to the county board. Wait 48 hours, wait till you have a diagnosis, and then you can report it. You will not be in trouble for not reporting something when you do not know that the criteria for that MUI for a hospitalization has been met. We want to make sure that we are reporting MUIs once they meet that threshold and not before. So again, 48 hours has to meet that criteria, also has to be one of the 6 diagnoses, or part B, which is readmission for the same diagnosis within a 30 calendar day. A couple more examples just to kind of illustrate this, because we know this is really a different change. Jose is admitted to the hospital for 4 days for bowel obstruction. Again, more than 48 hours and one of the 6 diagnoses listed there. Mary's diagnosed with dehydration and she's admitted to the hospital for 3 days. Even though that's something that Mary is prone to, and it could be listed in her plan, because it's one of those 6 diagnoses, it's over 48 hours, that is going to be considered an unanticipated hospitalization for Mary. And we know, again, that this is going to take some time and working through, and we'll provide additional guidance and examples, and we'll work with you, and we can always, collaborate and consult over the next 3 months, and we'll get through this together. Again, lots of great questions in the questions section that we will address. The other thing that we made a change to the rule is around systems issues. So systems issues currently are addressed in the definitions for the MUI rule, but what we specifically call out is these should only be used when it is a substantiated MUI for neglect. That does not mean there aren't systemic issues with other types of MUIs, but they should be addressed through the cause and contributing factors. For example, we should not have a systems issue failure to report, because the failure to report definition is a person who knowingly should have reported something and didn't. So hopefully that makes sense. We may have a person or persons. There may be a cause contributing factor that maybe this agency didn't have a culture of reporting, or maybe people didn't follow up, but there shouldn't be a systems issue failure to report. Those are going to be just utilized for neglect MUIs. And now I'm going to turn it over to Scott, and he is going to talk about reporting requirements.
Thanks, Connie. Appreciate it. We're going to keep moving here because we still got a little bit of stuff to get through, and we're down to about 15 minutes. So not much change here. The thing to point out is to make sure that we document the measures taken and by whom on the incident report when it comes to this information. So, and you can kind of see that red section, the end there, provider will document reasonable measures taken and by whom in the incident report. We kind of reiterated the information about people being placed on leave for physical abuse or sexual abuse, and making sure that happens. And we can kind of see that in the next one as well. We talk about, this is really dealing with agencies. So this was brought up by our DSPs on the committee, and they were concerned about not knowing what happened if maybe they were placed on leave regarding an MUI. And so we've placed some information in here that says, we're going to make sure that somebody at the county board, if it's a county board person, someone at the provider agency, if it's a provider person, is identified to be able to be a support for somebody who's a part of an MUI. And so that's pretty clear. It's just somebody who's knowledgeable at MUIs, someone the staff person can talk to and try to make sure that they're able to do that. And we've got this for both agencies here. And I think the next slide talks about that for independent providers as well. The last thing that really I talk about is the third bullet here that talks about, you know, in conjunction with the department, the county boards will have the authority to remove an independent provider from direct contact when a situation happens involving physical abuse or sexual abuse. There were some questions through the committee about how independent providers will be handled in this regard. And certainly the department and county boards are both, you know, in support of being able to do this to protect somebody. And you do it until that we've identified when that person either can come back to work or when we've identified that something truly has happened and we got to take further action. So both some important pieces to the addition to the rule. All right, I think I'm going to turn things over to Chris Young to talk about some of our children's services changes here.
All right, thanks, Scott. So we'll continue to go through these slides. So this first slide, abused or neglected children. Not a whole lot of changes here in these next few slides, but in summary with this one, we know the difficulty in some counties working with children's services. We ask that you continue to try and reach out and meet and explain your responsibilities for individuals served. If you're not getting any type of investigation from CSB, but possibly a limited verbal conversation or of what occurred, or possibly solely a disposition letter, we understand and ask that you place any known information into the report, no matter how small. Okay, and that'll be your report piece, and then do the best with the team to address constituting factors and prevention. So this next one continues abuse and neglected children. Again, once known CSB is not taking the case, we ask that you then proceed with your administrative investigation as you have always done so well. Notification, Section H, notification requirements for MUIs. Staff of an agency provider will inform the director of operations or administrator of the agency provider within 1 working day following the day staff becomes aware of a potential or determined MUI involving those misappropriation, neglect, physical abuse, or sexual abuse. All right, so basically for this one, the terminology changed. It was senior management. Now it's the director of operations. Also, the previous time frame for this notification was 2 working days. The committee felt it was best to go down to 1 working day. And that's really to ensure the director is aware of the MUI, as well as for these types of categories, as they may want to identify further immediate actions, more prompt retraining, things of that nature. So again, it just makes sure everybody's on the same page. And again, the provider will make the notifications, and per rule, the county board will still make sure that all notifications have occurred. General investigation requirements. In summary for this slide as well, for category A timeframes, they will still be initiated no later than 24 hours. In category B, no later than 3 working days. So the same timeframes relate. General investigation requirements continued. So section I, general investigation requirements, further states initiating administrative investigations means any of the following. 1, interview the reporter of the incident, gather relevant documents such as nursing notes, progress notes, or incident report. Initiation can also pertain to notifying law enforcement when there is believed to be a criminal act or the local CSB entity, and initiating interviews with witnesses or victims. And I will pass on to Dustin.
Thanks, Chris. Thanks everybody for hanging in there. I know this is a lot of information all at once. For this section here, all category C MUIs are going to require administrative review using the applicable form from Appendix C, D, or E. The applicable administrative review form will be submitted by the individual's provider and completed by an IA or investigative agent in collaboration with the individual's team. And upon submission of that form, the IA has 3 working days to initiate administrative review of the form submitted. And during that review, the IA can ensure information was coded properly and resolve any issues, questions, or concerns outstanding with the individual's provider or team. And during this time, that identification of causes and contributing factors and prevention will also be addressed. If law enforcement or a public children's services agency begins an investigation and requests a delay, the investigative agent or IA may postpone their own investigation, and the delay period must be mutually agreed upon between the IA and law enforcement or children's services entity. And this is going to ensure that law enforcement or other agencies can always take the lead as necessary. It also ensures our investigators don't duplicate efforts or interfere with ongoing criminal investigations. Instead, they can align efforts and coordinate findings. Additionally, here you see a lot of red, except when law enforcement or children's services entities are conducting an investigation, the IA will endeavor to reach a preliminary finding regarding allegations of physical or sexual abuse and notify individual's guardian and provider of those findings within 14 days. If not possible, then the IA will provide a status update every 7 working days until findings are finalized. And this is really about adding an extra layer of accountability, and goal being to keep communication flowing to prevent unnecessary delays. IAs will complete a written report in the format prescribed by the department for each administrative investigation or review, and the IA will submit that item for closure in OITMS, or the Ohio Incident Tracking and Monitoring System, within 45 days. This was previously 30 days, so I know a lot of people are throwing a party out there, and they should. So 45 days, you get an extra 15 from submission of the incident report, unless an extension is requested by the IA and approved by the department. And if an extension is granted, an interim report may be required, and also other actions may be discussed and considered to assist with the timely conclusion of that report. I'm passing it back to Connie.
Thanks, Dustin. I'm going to try to talk really quickly, so I apologize. This was something that we are already doing in practice, that a PPI, if that's an independent provider or a DOO or an agency administrator, cannot dispute the findings of a written summary. So that was already in practice. We just further clarified that in the rule. We did change a couple of the MUIs that the department closes, excuse me, versus ones that the county boards close, and you can see those here. One thing that we heard is that people wanted to do away with the requirement for independent providers to do annual analysis. And so we did, and we hope that the county boards and COGS still capture any trends with independent providers, but county boards nor independent providers are required for requesting or completing those annual analysis. As far as requirements for UIs, all providers, whether they be independent providers or agency providers, are required to do their unusual incident log monthly. However, they are not required to submit them to the county board, nor is the county board required to ask for those. So that's one big change. The other change is we further clarified that if you are a provider and you have no UIs for that month, you still are required to document that and review that on your log. So we wanted to carve out specifically hospital stays that do not meet the criteria for an MUI. And we want to make sure that the provider and the individual's team review that for anything that led up to that hospitalization, anything that might have contributed, so we can work on prevention for that. So again, UI logs are required to be done. They will be reviewed during provider compliance reviews. However, county boards are not going to be requesting them on a routine basis like they had previously, and you do not have to submit them. You still have to make them available for any department or county board staff that request them. And then finally, one of the another minor change is that whether you're a county board member, a county board member, or an agency board member, you will only be required to do MUI rule training within 90 days of your appointment. You will no longer have that requirement to do it annually like you did with the previous rule. All the other training requirements have stayed the same for DD employees, direct care, and then people not in the direct care. So the only change for training has been around board members, and that was to discontinue the annual MUI rule training. The other changes are pretty minor and listed here for your review. We did add a specific protocol under Appendix B for attempted suicide investigations. We've seen an increase in suicide deaths and attempts, and we wanted to make sure that we are addressing those. And then we just called out specific things that maybe needed to be addressed in our role and hadn't been. And now I'm going to turn it over to Scott.
Thank you, Connie. Appreciate it. All right, guys, I knew that was going to be a very quick hour, and that was a very quick hour. A lot of information, a lot of good questions. I've been trying to go back and take a look. A lot of really good questions. We knew that it was going to be hard to get the information in within the hour and then have to have a lot of time for questions. But as Connie mentioned earlier, we definitely will review all the questions, get back to you with those questions, and address those issues as we can. We are excited. I mean, I know that obviously this is all new and you're all digesting it. And we're trying to make sure that we put together some good information so we can process, this system and your questions very well, and make sure that, we're going to be well prepared when July 1 comes. Everybody's going to know what to do, how to do it, what makes sense. And I appreciate all the good questions, because you're going to give us some good information to have some Q&A with next time we do trainings. And this is all good. And I mentioned to our guys when we got started today, this is our first, and we are going to really, really get better at this. So there's going to be a lot more training in person, virtually. We're going to share more and more with you. And, I want to end it by saying we've got a fantastic MUI process right now. You guys do an amazing job. We're one of the best in the nation, and we're going to get better. And as soon as we are able to kind of fine tune this and get it together, it's going to only allow us to be more efficient, more effective, and better stewards of our taxpayers' dollars, and being there to support the people that we care about the most and to keep them healthy and well. So I appreciate all of you. Thank you so much. If somebody did not get in, please tell them, don't worry, not a problem at all. We are going to have so many of these trainings, and this will be recorded, and we will also have the answers to your questions posted as well. Connie, Chris, Dustin, Hannah, anybody else have anything else before we let folks go? I like to be conscious of people's time.
I was just going to add, we will email everyone the handouts again. Please check your junk folders but we will email everyone again. You'll have it there. Also a link to where to see the taped webinar and the postings. And then we will get your email certificate emailed to you within 30 days. So be looking for that as well. We've also included our contact information at the end of this presentation, so you have that and can contact us with any questions. And we'd appreciate any feedback on how we can improve this presentation, besides maybe talking faster. I'm not sure, but we'll work together to make sure you get all the resources. So thank you so much for all you do and for participating today.
Appreciate it, guys. Hannah, did you have anything else? We all good? All right. Thank you very much.